Well, good morning and good afternoon. Welcome to our March edition of Willis and Friends, and I'm thrilled that you've joined us again today for a conversation about At the Feet of the Storytellers, the development of early relational health conversations. So welcome again for joining us. Early Relational Health Coordinating Center at CSSP seeks to advance the framework of early relational health across all of our early childhood communities and to make visible, innovative, and scientifically based, impactful approaches with careful attention to racial justice, anti-racism, and health equity. All of our efforts are to bring about a paradigm shift for child health care transformation and community building. I'm really fortunate with my sessions that I can share with you my most valued colleagues, thought leaders, and friends who inspire me as they embrace the network of early relational health, equity, and put it into action. And that's surely true today. Let me try to set the context of today's discussion. The promotion and support of early relational health begins with authentic, unbiased, and respectful conversation with families. We have to always focus on families' hopes, dreams, and strengths. And as we witness those precious moments that families experience with their infants and young children. The support of early relational health is far more than providing general guidance or parenting education or screening for early relational health or making referrals. Champions for advancing early relational health understand the importance of partnering with families, embracing culture and equity, addressing the facts of community context in which families live, and supporting their assets, their strengths, and their hopes. So as child health and family support programs seek to promote and support foundational relationships with all young children, physicians, clinicians, and providers must be joining by reflecting on their personal perspectives and biases when engaging with families. So then entering conversations with families, they can begin that wonder at the strengths, the assets, the resiliencies that families possess in face of challenges, history, and discrimination. That joy then can be experienced by supporting the vision that families have for their own families' futures. It's in those moments that early relational health conversation with families can bring hope, healing, and authentic conversations, brings us to the feet of the storytellers. That's what today's session is going to be about. And I'm really thrilled to have two of the three developers of the early relational health conversation, Marie-Celeste Condon and Dominique Charles-Souillet, to be with me today. They're going to describe their experiences and thoughts about this good work. But let me tell you first about each of them. I met Marie-Celeste nearly 15 years ago. Isn't that right, Marie? Wow. When I visited University of Washington at the Barnard Center with the late Catherine Barnard and then with Sue Speaker about then what we had begun the work around what was a video-based effort called the Behavioral Health Screen that was then renamed with actually Marie-Celeste's guidance to the Relational Health Screen. You'll hear much more about that journey as that work moved forward. And Marie-Celeste Condon is an infant, early childhood mental health clinician, researcher, reflective consultant, and supervisor in the Great Northwest. She holds an Indigenous worldview, centering respect, relationships, and balance to her work with infants, young children, families, and providers. She's worked in early childhood home and center-based programs, child health care setting, pediatric setting for over 30 years, and her research is focused on family-centered diagnostic early intervention, the infant's experience living with their incarcerated mothers, and the families and providers' perspectives on early relational health. And then you'll hear about the work today she's done with Dominique Charles-Souillet. And then Dominique Charles-Souillet, she and I met when I was at HRSA in DC, and I had the privilege of participating when Marie-Celeste came to Children's National to present about the early relational health screen work at the invitation of Matt Beal and Lee Beers, who are really interested in bringing the early relational health into the Early Childhood Innovation Network in DC and the Healthy Steps Pediatric Model. And thereby then Dominique was a strong part of that work, and they took it from there. Dr. Charles-Souillet is a psychologist, a Healthy Steps technical assistant for Georgetown's ESIN, Early Childhood Innovation Network, senior policy associate at Georgetown Center for Child and Human Development. Her work is co-situated at Children's National and the early childhood sector. She has over 25 years experience working with birth to 5 populations, served as an infant early childhood mental health consultant for Head Start in the district, And her work has been co-principal investigator with the SAMHSA grant for early childhood, which aims to increase the capacity of early childhood educators to recognize and respond to the social emotional development of young children. And her current research is focusing on provider well-being and early relational health, and now this work around early relational health conversations. So I'm thrilled to have both of you join me today. And so welcome, Marie-Celeste and Dominique. And so let me give each of you a chance to talk at some length about your experiences, your reflections that have been along this journey as we come to try to advance early relational health with families. Your thoughts about these initial experiences about the concept of early relational health screening promotion, and then the development of the model of early relational health conversations and where these efforts are today. So, Marie-Celeste, can I come to you to start?
Yeah, sure. David, when I think back to when I joined you in the work, I remember feeling struck by the value of thinking about well-being in terms of mutual capacities that exist in relationships between babies and young children and their parents and caregivers. Helping parents, caregivers, and service providers recognize indicators of mutual capacity in relationships they were co-developing with their babies. Helping them pause to notice what they were feeling and thinking, to be curious and give voice to their hunches about what their baby was experiencing, perhaps thinking or feeling what baby might have been thinking or feeling, perspective taking, in other words. Mm-hmm. This was transformative. In my experience, babies, families, other caregivers are fascinated by discovering how much they mean to one another. Yeah, it's a beautiful thing to watch. It makes sense to parents and caregivers that their relationships will, and the capacities in their relationships will grow and develop over time as the baby and their relationship with the baby matures. It makes sense to them that early relational health is protective in the face of adversity. They're so happy to hear that science is catching up with their cultural wisdom. It's useful to be able to, as clinicians, it's useful to be able to discern when indicators of positive, overarching affect in the relationship and mutual capacities are robustly present and not so much. However, it's a mistake to think that we've come anywhere close to identifying the diversity of ways that early relational health can be expressed and manifest in family-baby relationships. We need families to help us recognize and understand the significance of behaviors that protect and hearten emotional and social well-being in their cultures. In my experience, it's often tricky for practitioners who are accustomed to doing screenings and assessments that put the practitioner in the role of observer, question asker, rater, scorer, interpreter of findings, giver of recommendations, and guide to resources and ways to remediate weaknesses. It can be really tricky for them to make a shift to thinking about inviting and engaging families in a more partnership focused way of looking at early relational health. So I'm a researcher, and I can see that rating can be useful in some types of research, but not in early relational health focused mutual endeavors with families. Rating relationships, and particularly families, rating relationships, and particularly doing ratings of relationships with families with racial identities and other identities that have been and continue to be marginalized, oppressed, and seriously harmed in our society can feel dangerous to families. Furthermore, results can be seriously confounded by implicit bias. And so I think that takes me in my journey in terms of thinking up to when you and I met, Dominique.
Yes, how I remember that time well. I remember where we were together at Georgetown.
Yes.
So when this collaboration began for us, what was important to two psychologists of color was putting family voice and culture at the center of early relational health focused visits. The
Mhm.
families that we were so privileged of working with, of working alongside, we were privileged, but they had a vision of what they wanted for their babies and the kind of legacy they wanted to leave behind for these babies. So we understood that. We
Yes.
understood that these aspirations existed also alongside the reality of systemic oppression, that we had to really give space to both of these realities. So, equally important was the approach of an early relational health focused visit, was that we wanted to have this through the lens of a strength based framework, not a deficit framework. There's an old Nigerian proverb that says, "We are what our thinking makes us." We did not want our thinking to be grounded in a Eurocentric, linear, hierarchical discourse. We wanted, we were intentional about positionality, and that
Mhm.
positionality was us learning through the voices of our families. That was what was important. And so our journey began, right, Mary Celeste?
Yes.
Yes, and our stories began.
Our stories began.
Yes.
So before we talk, this is incredible, and you've so shaped my own thinking and then so many others about this critical way of thinking forward about this work. Before we go to the stories, I'd like to ask each of you to also share, the how you came from when we first met about quote unquote early relational screening. As
Mm.
first thought that is what Lee and Matt
Mhm.
first brought in
Mhm.
to then that little journey towards now how you're thinking about engaging the storytelling of
Uh,
families and that how that actually happened a little further because I'm certain that as people at many levels start absorbing what we're talking about here about early relationship
mhm.
conversations, they may well have to go through that aha experience.
Yes.
Can you talk about that a little bit? Then let's go to some storytelling.
Sure, sure.
Do you wanna speak, Dominique?
Well, for us, again, as we sat and we listened, and as two psychologists experienced with doing assessments, we knew that this was not the place for that. We knew that screening, it felt very risky to a population who have been historically marginalized. And so, how do we begin to create a different dance, a different song, a different outcome?
Mhm.
So,
Mhm.
from the point of onset, if you remember, Marie Celeste, we asked questions. We
Yes,
were
we did.
we were very intentional, and we wanted to ensure again family voice was first. And it was
Yes.
clear to us that screening might not get us there. We
Yes.
wanted to learn from our families. We
Yes.
wanted to hear about their dreams and situate ourselves in a place such that when vulnerabilities emerged, that
Yes.
they were comfortable in saying, I
Yes.
noticed this. What can I do with that? But it
Yes.
was not the heartbeat of the exchange.
No.
So
Um,
that's
um,
my recollection.
well, I remember sitting at the table listening and watching exactly that comment that
Yes.
you and a couple other Healthy Steps providers brought forth. And yet, this good work has continued. How about for you, Marie Celeste? Your thoughts about this transition?
Yeah. When I think about um, besides besides the time that I got to spend outside the training, Dominique, with you and Dr. Hodgkinson, I'm thinking that moments that stand out is when Dr. Lee Beers invited me to be a consultant with you all in
Mhm.
doing a quality improvement project
That's right.
within your Healthy Steps primary care settings to see what would it be like to be implementing this in person. And what I remember in that conversation was my asking Lee if she would be up for us including a study of phenomena like what the experiences were of the families, what the experiences were of you as Healthy Step specialists with this. I thought we could learn from your experiences and watching how your thinking might change over time. And so I remember us meeting often over, I think it was at almost 2 years. Yeah, and the brilliant thing was that we had this space, this reflective space that we co-created, and you all would bring not only the videos of the families and the babies in interactions, families, not dyads, but
Right.
families and babies in interactions, and you were so brave. You also brought videos of yourself interacting with the families and the babies. And then we would watch those together in a process that paralleled what you all were trying to do with families, like not me pointing things out, like as a consultant, but you all noticing what was going on for you in that moment, what was coming up, those reflections we caught.
Yes.
And that became the data, the qualitative data that we used in a discourse analysis that we used. I remember the moment when you and Tanika Rahman and I were analyzing our data, and we went, oh my gosh, we have a new model, a model for a different way of being with families in early relational health.
Yes.
I wonder that's phenomenal. And Dominique, I wonder if you can comment about a little bit for the audience about video within the encounter, just so the frame is set.
Absolutely.
There's a story element.
Yeah, absolutely. So once the relationships were forged with families, we invited families to make a movie.
Yes.
You remember that language?
Yeah.
We invited families to make a movie of the interaction between families and babies. And as Marie Celeste said, it was not dyadic. Sometimes triadic, yes, but mostly family-centered. And so once we made the movie, we had we invite families in and allow them pause to settle in. And they were more than willing to allow for a 7 to 10-minute videotaping of the exchange, where it was the exchange between the family and the baby. And I sat just present, enjoying that exchange. And after, we jointly looked at the video, and I asked the parent, the family, what stood out for you? Any discoveries? And it was a delight to hear what stood out, the points of growth that many families spoke of, from the point of when babies arrived in pediatric primary care to when they were now 3.5 months old, and the points of vulnerabilities that they saw. And then the next question that followed, what can I do to support this baby in continuing with the development? That full circle moment. And then asking families if they were delighted to receive the videos. Of course, all families wanted that. We then would submit the videos to the families. So it was their video of their narrative of their storytelling.
And to be clear, first of all, it's, for me, that's paradigm shifting at so many levels, and a new way and a new model of thinking. And also, as a reminder, this was in the Healthy Steps model.
Yes.
In the clinic.
Yes.
In a clinical operation in DC, correct?
Yes, correct. And again, we certainly face challenges, as you can well imagine, in a pediatric primary care setting that's busy. Workflow is important, all of those things. And so with intentionality, carving space for this kind of early relational health conversation, it was challenging. But we continued and we forged forward.
I remember the pacing.
Yes.
Dominique, I remember how much care you all took to loop in the pediatricians, the nurse practitioners, the nurses, the people who greet families at the front desk.
Yes.
Yeah, how much care you took into over time in coming up with like job aids for yourself and for other people, and then revising those as you get feedback from families. Yeah, there was such care around pacing. Actually, David, when I think about it, a lot of those mutual capacities that we have identified existing in relationships when they're beginning to form between families and babies, like mutual engagement, mutual responsiveness, mutual initiation and sharing of ideas and everything. Dominique, you and the other Healthy Step specialists made sure that that was part of the experience of the people. So it felt like something that everybody had a part in, you know, heartening these families around the well-being of the relationships with their kids. I think that was part of the brilliance of it.
And it was about being with families.
Yes, yes.
In that parallel process of the context and the perspective and the heart of the clinic as a whole.
Yes.
And all the people involved carrying the relational framing in every way of doing so. That's really phenomenal. So I know at the heart of your model is storytelling.
Yes.
Yes.
I wonder if some stories come to mind that you could share with the audience.
Well, yes.
So many.
So many. But you know, David, Dominique, and I were thinking that maybe an important one for us to share would be the story of what early relational health focused visit was actually like.
Wonderful.
And so we call this story Nia's story, and in Swahili, Nia means purpose. So imagine that you're in a room, and that the family and the Healthy Step specialist have come to settle themselves in comfortable ways on the floor, and the family's brought like a blanket for their baby, and so now you get to look in on this scene. So imagine observing this tiny 3.5-month-old baby girl with her dad, her mom, and her 4-year-old brother. So this baby is overtired and fussy because she's just had a shot. Yeah, she's crying. Mom tries to settle her. Dad takes her from mom and holds her in the crook of his arm and offers her a pacifier. She sucks and starts to settle, but Dad takes the pacifier out of her mouth and she starts to fuss. And he gives it back and she settles, and he gently takes it out again. And if you were the Healthy Step specialist, you might be wondering, like, why doesn't he just give that baby the pacifier? The 4th time that Dad takes the pacifier out of her mouth, baby doesn't fuss. Instead, she just kind of studies Dad's face, and he nods and he tells her, "You are strong." He lifts her up so she can see mom, she can see brother, and they lean in. Mom leans in, brother lean in, and they catch her eyes, and they smile and they greet her. And baby's droopy eyes begin to close. And as she falls asleep, mom says to her, "We are here for you." And then everyone is quiet in the room. Everyone just gazes at the sleeping baby for more than a minute.
Yeah. That I remember that so well. I remember that story so very well. And the Healthy Step specialist who led that early relational health conversation.
And there's others in our network that are talking about emotional connection.
Yes.
And that was, and all the elements that we've been recently discussing.
Absolutely.
Observable in that mutuality, in that sense of eye contact shared, in that vocalization, in that careful touch, in that sensitivity and attunement. That emotional connection is palpable, observable, and you just described it in many, many, many ways in that moment of discovery, which is so powerful.
Yes.
And I just want to highlight something in there. Do you hear or see the Healthy Step specialist saying anything or interpreting anything? Nope, you don't. Even though she had some wonderings, and she was so mindful of what was coming up for her.
Yeah.
And so then she could lead with asking wondering, asking mom to highlight what stood out for her, including brother and highlighting what stood up for him, and turning to dad. And it was in that we came to understand the significance of that pacifier in and out behavior. So when we think about it, a pacifier is like an object. And would that be the thing that would comfort the baby, that would settle her, that she could turn to in times of distress? That's not what her family was teaching this 3.5-month-old. The message they were teaching is, look to us. We are your family. We are here for you.
And you support you. Yes.
We are here to see you, to support you. And so then when you think of it that way, you can understand dad's behavior in a whole different way.
Right.
You can still imagine the glow that was happening, but you can understand the baby and the values, and you get a chance to see a different way that well-being can be expressed in relationships that many of us haven't been gifted with the opportunity of learning yet.
So lean in as to, from the Healthy Steps role in that moment, how would they define themselves as that space?
In that moment, a wonderful observer of, and really the willingness, and that it's easy in that moment to focus on the pacifier. It would have been easy to focus on the pacifier being placed, being removed, being placed and being removed. And if one allowed oneself to just stop at that exchange, the richness, the wisdom of the exchange would have been lost. And so the Healthy Steps specialist sat with curiosity, with openness and inquiry to really join with the family, to inquire, to ask what stood out for them as family members, as Marie Celeste said, what stood out for the 4-year-old.
Yes.
And the 4-year-old had a voice. And so it became really the departure less from the focus on the pacifier to then the narrative that was created in this space and place with this family.
So the Healthy Step provider role was inquiry,
Yes.
and inviting discussion. I'm just trying to think about elements.
Yeah. So I hear what you're saying, and David, and the thing about it is, if I can just use my hands to, let me see, I better move this so I can see my hands on the screen. Body awareness not being my strong point. So if I could use my hands like this, how do we do that? Is that something? There we go. So when I do this, we can think about this being the space. I just have the hardest time with this camera. So this can be the space, the knowledge, right? And what the Healthy Step specialist did, instead of taking up the fullness of the space with her knowledge, like pointing things out that glow, pointing, wondering, asking questions, what she did is she didn't disregard what she's saying, but what she did is she made big space for the family wisdom. And so she didn't have to highlight mutual responsiveness or mutual engagement. The family could do that. She didn't even have to ask them direct questions. All she had to do was to show, not only by her words, but by her actions, that they were partners and that they were discovering something really amazing. And so I think that's her positionality changed. And when she shifted that, the family could step forward. And that experience of being the one to give voice to the insights, the significant things, is just powerful. Think about how it is for us when we get to have that role. And so the family has that role. And then we talk about how then that belongs to them. And who is going to be living with and raising this baby? Not us, the family. So we want them to be having a moment where they can just relax and focus on their relationship and exercise their reflective capacity.
But
So,
also a moment of affirmation and
yes,
a moment of claiming their relationship narrative.
yeah,
So, Dominique, I want to lean in on the model.
Mhm,
I want to lean in too. I mean, thinking about this is within a health system.
mhm,
And the health system has its responsibilities and its expectations,
absolutely.
et cetera, et cetera, et cetera. You know all that.
Yes.
Talk about the model and the components. And again, even reflecting as the question I was asking as to the Healthy Steps specialists, and let's assume future specialists of all ilks begin to have interest in this approach.
Mhm.
Talk about the elements and then talk about role definition and role partnership and those kind of efforts as you move along in the core elements of the model.
Sure, sure. So the model has 8 components. The first is assessing strength and knowledge in a healing centered space. So, where both comfortable, uncomfortable, pacifier in, pacifier out, uncomfortable and comfortable situations and events can be seen, can be discussed. But we have to also create space in the second part of the model is pausing and co-creating, giving families time to say, "Whew, let me get settled into this space. Let me arrive and get settled in." In the case of Nia, Nia had just had a shot. And so to allow Nia to get settled in, for dad to position her in a manner that felt comfortable and the like. So this is where we create that mindfulness moment for families. Storytelling is the third component, and you've heard already about our stories. The family baby interaction is the storytelling. The families decide when they and their baby are ready to begin videotaping. So once they settle, they let us know, okay, we could start now, or I need a little bit more time. And so we provide that. Next part of the model is witnessing, family witnessing and watching their narrative alongside the early relational health conversation provider. So we're standing alongside this family. And we talked a moments ago about positionality. We often sat on the floor just watching in a little bit, creating distance between the exchange between family and
mhm,
baby so that we're not contaminating that exchange. And
mhm,
sometimes the baby wanted us to be involved as well, and that's fine. But really, the central point was family and baby. So the sense of mutual reflection is the next component of this a model where family members and the Healthy Steps specialists make meaning out of what they saw. Families draw on their personal cultural experiences, their knowledge, their wisdom, and help us understand what we saw in this narrative. And as I shared earlier, affirming and claiming the relationship narrative is also part of this component. The moments of discovery of what we just saw and experienced. And then mutual insight. Mutual insight is about summarizing, planning with the family. What would you like to do next? How can we journey on this road together? And that is led by the family. So these are the 8 components. And part of the mutual insight also is that it extends to the reflective supervision and consultation, which is where Marie Celeste comes in allowing for that parallel process that we just spoke
mhm.
of, where we're then really looking at this in a reflective supervision and consultation space. Would you add anything more? And that's within itself is a paradigm shift,
Yes,
right?
yes,
So,
yes. Especially, I think maybe in pediatrics or in
yeah.
medicine, where oftentimes those practitioners haven't haven't aren't in spaces on a regular basis where they can reflect on their practice, where they can be yeah, something that's protective around burnout, compassion fatigue,
Mhm.
secondary trauma, and something that helps them continue to grow in their awareness of themselves, being able to always be thinking in a situation not only about the indicators of relational health, but also to be thinking about what might be the assumptions or the biases or the equity issues in this situation. And yeah, so in that way, consultation helps.
Self-awareness, yes.
Self-awareness is huge, and that helps practitioners, I think, maintain fidelity to a model like this.
Mhm.
But it also has the additional benefit of starting to chisel away at the systemic racism that exists in systems.
Yeah.
I so appreciate the model and the articulation and the elements. I wonder if you can share with me too, when families are, bedraggled by the challenges around them, the world they live in, the history of the realities of their living experiences, or their own, experiences that have been challenging. And how does the model approach, explore, bringing support to families that when one is sitting with them, one witnesses the pain and the struggle? How does that shift from the moment of narrative, experientially, to our health system's hope to build, promote resiliency and strength and recovery and healing? How does the model fit within the health system's goal, hope, of resiliency building and support of families? How do you think about the way these things connect?
Yeah, that's a great question, David.
Mhm.
I think this model really is one that's future thinking in many ways in the field.
Mhm.
One that the past 2 years, what this entire world has experienced, when families are now, when families were allowed to come back into pediatric primary care, I cannot imagine how one could not pause and reflect on the journey, the losses that our families, especially so much, and as the data clearly informs us, so many families of color really had significant losses during this pandemic. And so, walking in a pediatric primary care room and space, the notion of this model creating space to pause and allowing families to settle and to speak about the reality that they've just experienced
Mhm.
and how that reality has impacted their child rearing, their experience, their relationship building with this little baby. I think it opens
Mhm.
up the gateway of going beyond the checklist, going beyond how much did you weigh, going beyond all the checklists, looking at the Eppenberg, the EPDS of whether or not mom is
Mhm.
experiencing any depression or the like. It really pauses to ask
Mhm.
questions. How are
Mhm.
you, mom? How are
Mhm.
you doing? And seeing mom, which is one of the things that I so appreciated with this model, mothers saying and fathers saying and grandmothers saying that I have never been in a setting where, yes, it's about the baby, but it's also about me. It's also about me, how I am doing for the care of my own care, because I know once I am whole, then I am more available to really raise this baby. And so I think this model offers really a different way of thinking about
Mhm.
the engagement of families in a pediatric primary care setting.
Dominic, do you have a sense of, because pediatrics has multiple visits
Yes,
over time,
yes.
how does the model and the continuity of care, that sense of multiple visits, play together? What are your thoughts and experiences?
Well, again, we unfortunately, during the time that we had just started this model, the pandemic happened. Our intentions were to be able to really have this model across the developmental lifespan of this baby at that 4 months visit, and then doing it again at the 6 months visit, and then doing it again so that mom and dad and grandmas could see the trajectory of growth and development through this video that we offer families so they could see their narrative and how the progress and the
Mhm.
exchange in their relationship. So with the Healthy Steps Specialist, which is really the core of that model is relationship building. It provided us with an opportunity to have different points of entry with families and then creating opportunities to do early relational health
Mhm.
conversation at each interval of well child visit, if that is what the family desired.
Excellent. Marie Celeste, thoughts or thoughts you want to contribute?
Yeah. For one thing is I just love how beautifully you were reflecting and expressing that, Dominique. I just
Yeah.
really appreciate that. When I think about things that, yeah, that could be obstacles or challenges, is I think about how many times babies and families see different providers. And
Mm,
so this is a really important work, and it fosters more than a rapport, like a relationship between the provider and the family. And so to do that work of a mom or a dad or a grandma feeling, or whoever, feeling that their care and well-being is tied to the baby's well-being, taking that risk of being vulnerable in this space, that becomes really difficult if you're hurried and if you're seeing different providers. So
mm,
I think centering relationships is going to be something for settings to think about, not the sometimes unfortunate, nobody wants it, but rapid shift that people have in caregiving. Another thing that I think is tricky is that in a busy setting, it can be really hard to pause,
yes.
and take a breath and notice what's coming up inside oneself, and then to observe, like with as much of an open mind or as possible, what's happening before you jump into doing. I just think that the risk of hydroplaning, is huge
Yeah.
in a lot of care settings.
And that's why we say that early relational health conversation is about being with, not
Mhm.
doing for, but being with families.
Being with
Being with families.
families.
And you're absolutely right, creating time for just breathing.
Yeah, for breathing.
As I often said to pediatricians, as you put your hand on that knob to open that door, how about pausing and just taking a breath before walking through the door? And also helping our families pause and take a breath and settling in. It is that parallel process.
I'm so excited about this conversation, as you can sense, the energy and the forward leading effort. The AAP put out a policy statement about advancing or preventing toxic stress, partnering with families and communities to promote relational health. It's a game changing policy statement that is of decades in the building. And it calls out within it,
Mhm.
focusing on safe, stable, nurturing relationships and buffering adversity, building resilience, and says pediatric care is on the cusp of a paradigm shift,
Mhm.
reprioritizing clinical activities, rewriting research agendas and advocacy. But we're talking about reprioritizing clinical activities. We
Yes,
capture the moment of the relationship and its critical importance in partnership with families, correct? I wonder what
correct.
your further thoughts are and what you're hearing and what you're sensing about this paradigm shifting in the world that you're in, what you're hearing of those around you. Can you lean in your thoughts?
Well, yes, I can. So where my thought is right now, I'm still hearkening back to what you said about pausing on the doorknob to
Yeah,
take. So I'm thinking, how about when we think about parallel process, if it sloshes both ways? So let's think about what we want to be happening between the baby and their family members, that kind of attunement and well-being, and then that's a process. And then that can inform how we want to be with the family and the baby, right? And then I hope that would inform the way a system would operate so that that provider is having a similar experience,
Yes.
generally in consultation, because it's really hard to sustain giving to other people what you're not receiving yourself.
Absolutely.
Yeah. And when one's in a hurry, when one is feeling like really a huge fiduciary responsibility in terms of care, those are the times when we are most likely to be operating out of implicit bias or procedural memories. Our notions about what it means to parent, how to be with, how to be in a particular role that we're not even aware of.
Yeah.
And so there needs to be spaces that catch that. And those are some of the things that I think about. I think when the American Academy of Pediatrics is so brilliant to center early relational health in healthcare, to say, yeah, this needs to be at the center of it. And think of the power of that. Think of what research tells us is going to be possible in terms of health across the lifespan, development, and all that. To realize the power of doing that, I think we're to really walk the talk. And I think we're going to need to think about how we support providers and making some shifts in practices like use of time and so many other things.
Use of time, use of how we look at CPT codes.
Exactly. Yeah.
How did we look at documentation of
Yes.
early relational health
Yes.
conversation? Because in a pediatric primary care setting, it's the baby that has the chart.
Yes.
Right. It's the baby's chart. How do we document? So it is an exciting season to see this shift. And it is one that there's so many different elements of it that will need to change in some ways.
So we're talking about health sector, and I'm an old pediatrician, so health sector matters to me. And Healthy Steps is deeply within that transformational process of health sector. Celeste, you and I met in home visiting.
You're right.
And you've had good experience in home visiting.
Yes.
And we know, the policy statement calls out that there's a parallel process for child health system transformation that's public health principles and partnering with communities deeply. So what are your thoughts about, the early relational health conversation and those relational health workforce people in the community everywhere from doulas to community health workers to visitors and the like? What are your first thoughts about how this model is applicable?
Yeah. Well, my first thoughts go back to attachment theory. So when we think about the different types of attachment strategies that children can develop, when we think about secure attachment, like, really, can a baby have too much security? Right? Can a baby have too much secure attachment? I don't think so. So if we set aside the idea of rating, screening and rating, and we lean into thinking that families could be experiencing in the pediatrician's office, in programs that provide early support for infant and toddlers, sometimes called early intervention, which can cross between clinical or center-based and home-based. If we think about all of the different home-based programs, I can see how people could be supported to in reflecting, growing in their self-awareness, in leaning into and learning this different way of being with families. And what would be the worst thing that would happen? Let's see. The worst thing would be that we'd be chipping away at anti-racism. We'd be chipping away at racism. And that families would be in different places experiencing, whoa, I know my baby, and you are with me, giving me a chance to reflect and experience being not like this, the recipient of a service, but a thought partner, thinking with in the service. And that pretty much everywhere I turn, people are recognizing how our relationship is what's sustaining and growing the baby, but also us. Because back to what you were saying, Dominique, about the pandemic, I just think that, families are suffering.
Absolutely.
Families are suffering. And so Winnicott used to say, there's no such thing as a baby without a parent, without a mother. And so I think that's what I think. And when I've brought early relational health conversations to childcare or early childhood centers or early intervention programs, and the provider is there in the conversation along with the family and the baby, and the provider gets a bit more support so that around being that way with families, and not only when I'm there to facilitate it, but at other times, they internalize this way of thinking about relationships. And I'm out of the picture, but they continue to look at the children and the families in that way. And then families hold on to that as well. And then I'm experiencing now, a year later, after I've seen these families, they're figuring out ways to get back in touch when they're going, whoa, we are experiencing a struggle now that our second born is here, and our firstborn is showing sensitivities and behaviors that are concerning to us, and we want to go through a discovery process in this way. Yeah, we want to do that even before we go and get a whole bunch of diagnoses. Yeah, we want to go through it in this particular way, and I just think that it's powerful that 30 minutes when a baby is 4 or 5 months of age can have an impact continue to have an impact at the time he's approaching 2-3 years of age. So I know I'm talking a lot, but that's what pops to my mind. Yeah.
We have a crisis of connection in this nation. We have a crisis of disconnect. We have a crisis of social emotional development, mental health, and the like. And so much, I think all of us collectively believe that deeper emotional connections over time are meaningful, powerful, but also protective, building that social resilience, or whatever words one wishes to choose, recapturing deep indigenous knowledge, deep historical, cultural, evolutionary knowledge is so essential. And yet there have been barriers and obstacles to this work. And, we're coming towards the end of our effort. We're going to need to finish up with some final thoughts, but I wonder if you want to make any comments about, the obstacles and then the opportunities of advancing the model. What are you learning? What are you thinking? What's emergent to you about the excitement of the opportunity?
Well, I think again, from my perspective in pediatric primary care, it is the notion that, the medical system really, as a result of the pandemic and every other system, right, has had to pause and think differently. And I think that is an exciting piece. It is an opportunity for us to really begin to change, to make a deposit in changing how this work happens, and who is in the room while the work is changing. We're seeing other people in the room to make the decision, to help shepherd the decision making as we're looking at this. Yes, there are challenges. You've heard us speak about the challenges earlier, the challenges of CPT codes and billing and records and workflow, and how to look at early relational health conversation, who provides healthy early relational health conversation, where and when. These are exciting questions in my opinion. It really is an opportunity to sit down with different disciplines to come together, and having family voice at the center of the conversation, not as recipients of this work, but really as thought partners of the work,
So
where we're not only honoring them, but we're also honoring the baby.
right. So how do you think about the building the evidence? Because we do live in an evidence-based world. How do we have an evidence-informed approach that shows that this approach is really meaningful? What are you seeing? How are you thinking about the research elements?
Well, Marie Celeste, you want to talk a little bit about our research? I mean, we certainly saw the value of it. Unfortunately, we only had a snippet of time to do the work. But the research is very important to be embedded in already an existing evidence-based model, such as Healthy Steps, to put another level of innovation in that model, uh,
Mhm.
to continue to really hear the voices of families to say the utility, to articulate the utility of this, both in terms of the qualitative data, but
Mhm.
also the quantitative data to be able to say that. And I know, we saw that in the qualitative data that we collected.
Yeah, I'm going. Um, yeah, I want to speak from an Indigenous perspective right now.
Mhm.
So then I think of so for me, that at the center, then it's not like Maslow's hierarchy. At the center, it's more that there's respect and relationship and balance
Mhm.
is at the center of all things. And so then I think about two parallel things needing to happen. One is like uh, being able to raise up the next generation of practitioners
Absolutely.
and giving them experiences that parallel what we want like to give to families. And then I think in terms of the research, I would like to see, especially with relationship to early relational health conversations, that we tap into the expertise of Indigenous scholars, Indigenous researchers, who value things like highlighting, understanding, and supporting the resiliency and strength of Indigenous people. But when I'm speaking, I hope you can think that this extends beyond people who have an Indigenous identity to Latinx, Asian and Pacific Islanders, African American
Yeah.
families. Yeah, they're the unique contributions that research done from an Indigenous perspective can offer to the field. And then, in terms of understanding and addressing problems, things like collaborative, community based um, inquiry that uses decolonizing methods. Yeah, sustaining
Community asset mapping,
asset mapping.
right? Yeah.
Yeah, healing centered digital storytelling,
Yes.
photo voice.
Phenomenal.
I think these are the ways of. Excuse me, my throat is going, but I think these are the ways of gathering evidence. Sometimes I think we think that evidence is is mostly quantitative, and I think there's other types of evidence, particularly when we're talking about
Well stated.
relational well-being.
Well
Yeah,
stated.
Yeah.
We're
yeah,
coming to the end of our time, and what a phenomenal conversation, my friends.
yeah.
Thank you.
It fills my heart. And I would love you to have some final thoughts. And Dominique, I'm going to come to you first, and then to Marie Celeste, and you need to finish up.
Sure. Thank you again, David, for this opportunity for us to be in dialogue. I certainly said this earlier, but there are missed opportunities when we explore family voice in a way that's a checklist format, that is about medication management, that's about building codes. There's a missed opportunity that we missed the conversation during the well child visit. Our hope is that we really train a new generation of pediatricians, psychologists, social workers,
Mhm.
counselors who are trailblazers, who will then focus on more of a liberation based healing that is equity centered at its core for the early relational health visit. That's about listening to the stories of families, of storytellers. Many of these stories are unscripted.
Mhm.
So that's some of my final words in terms of really just thinking about the future of this work.
Absolutely. And Marie Celeste, final thoughts.
Yeah, final thoughts and feelings. So the feelings are like of so much gratitude for being able to be in this space. I would just want to thank you so much, David, for giving Dominique and I a chance to like highlight and yeah, share our work and our hopes with other people. For me, I'm hoping that this might be a step towards us being able to partner with communities, partner with practitioners who would like to explore early relational health conversations, figure out the parts that are goodness of fit for them, and and that in doing that, that families will be at the table as co-investigators. Yeah, so
Thank you.
yeah.
To the audience, you've been with our trailblazers here about early relational health conversations, which stay tuned. There's far more that will come of this incredible work. Next month, again, on April 20th, same time, we'll be talking with Bob Sagi and some of his team around the Health Innovation Network, health outcomes and positive experiences. So continuing the conversations about the importance of advancing early relational health. So again, thanks to everyone.
Yeah.
Be well.
Thank you. Thank you, David.
Thank you.